Let us discuss about ECG reading and its usefulness in emergency medicine department. So first of all, we should know the physiology of heart, how the electrical activity go through the heart, conducts through the conduction system. We'll see first that and then we'll see what are the waves which can be produced by this electrical activity. Then we'll find out how to calculate the rate in ECG. Then we can see some of the rhythm abnormalities. So you all know that the electrical activity in heart starts from the SA node. SA node is present somewhere in the atrium. From the SA node, it's a autonomous system. It produces current in our heart. From that SA node, electricity travels to AV node. That is somewhere in the junction of atrium and ventricle. Atrioventricular junction, there is another node, that is AV node. From SA node, electricity passes to AV node. From there, it goes to the Purkinje fibers in the ventricle. So this is the basic conduction of electrical activity in our heart. You all might have learned this in detail in physiology. So we are talking about ECG, how the ECG waves are formed by this activity. So we already know that SA node produces current. That time you get a P wave. So this is a P wave in ECG. So P wave is formed by the SA node activation or the atrial activation. So electricity starts in the SA node. So you get P wave. Then there is a time taken to travel this electrical activity to AV node. That is PR interval. So onset of P wave to QRS, that is R wave, that is PR interval. That is a time taken from SA node to AV node. Then ventricle activates. The electrical activity spreads through the ventricle, that get activated, so you get a QRS complex. So SA node activation produces P wave. The time taken from the SA node to AV node, that is PR interval. Then ventricle activates, that is QRS complex. So you are seeing P wave, PR interval, QRS complex. So every heartbeat will have this process. So when we are feeling the pulse, you can see normal person pulse comes regularly. So you can call it a sinus rhythm. So we will see what happens in sinus rhythm in an ECG. We already learned that P waves are produced, PR interval is forming, QRS complex is coming. So PR interval takes 5 small squares in ECG. So that now we will see what will happen in ECG paper when we are getting ECG in a strip or in a big sheet. In that sheet you can see large number of small squares, and some squares accumulate or they form a big square. So you can see small squares like this. So 5 squares like this you can take, or you take only one square from this. The smallest square in ECG we have taken here. The speed of the smallest ECG square is 0.04 second. In that speed ECG paper is running. So the time taken of this 0.04 second. So we can see here PR interval is maximum is 3 to 5 small squares. So you can see here small square is 0.04 second. So 3 to 5 squares means 0.12 to 0.2 seconds. In that speed ECG paper is running. So PR interval is maximum is 3 to 5 small squares, whereas QRS complex should finish in between 2.5 to 3 small squares. So 2.5 to 3 small squares it has to finish, then we can call it as a narrow QRS complex. So what we are seeing in an ECG paper, the lowermost part of the ECG paper, you have a rhythm strip. From that rhythm strip only we are calculating the rate and rhythm of the ECG. For ACLS purpose we should know what type of rhythm it is, what is the rate of that ECG. So we will be learning how to calculate the rate and how to identify the rhythm in ECG. So here you can see this is an ECG tracing which may come in the rhythm strip. Rhythm strip you can see continuously PQRS complex will be forming. So there is one P wave, QRS complex, T wave, P wave, QRS complex, T wave, P wave, QRS complex, T wave, P wave, QRS complex, then T wave. So when you are palpating the pulse in a patient, you always tell patient is in sinus rhythm. So you are getting pulse regular interval, you call it as sinus rhythm. But ECG wise, to tell sinus rhythm, you should have a normal P wave, that atrial activity is normal, then every P wave should follow by a QRS complex. So atrial contraction or atrial activation should follow by a ventricular activation. Then ventricular activation should come in regular line. So the time between each QRS complex should be regular. Then only we can call it as sinus rhythm. So to tell sinus rhythm, you should have a P wave, atrial activity. Every atrial activity should follow by a ventricular activity, that is QRS complex. Ventricular activity should come regularly. Then you can call it as sinus rhythm. So whenever there is a ventricular activity, you get a pulse. That's why you are getting regular pulse means you are calling it as sinus rhythm. So this is the sinus rhythm ECG, what we are seeing here. Now we should know what is the rate, how to calculate the rate. It is very simple. You can see the QRS complex here and take another QRS complex. If the rhythm is regular like this, see the number of large squares in between two QRS complexes. So here large square means like this, 5 squares, a group of 5 squares will be a large square. So if you are getting 3 large squares in between two QRS complex, you can calculate like this, 300 by 3, the rate of this ECG will be 100. This is possible only if you have a regular rhythm. Okay, but no need to worry, in most of the modern ECGs, it will tell the rate of the ECG, whether it is regular or irregular, it will tell the rate. Now we will go to different types of rhythm abnormalities. So normal pulse, you all will be knowing, normal heart rate is somewhere around 70 to 100. That's a normal heart rate. If it is less than 70, it is low. If it is more than 100, it is high. If it is more than 100, we call it as tachycardia. If it is less than 50, we call it as bradycardia. So bradycardia means low heart rate, tachycardia means rapid heart rate. There are multiple reasons for bradycardia and tachycardia. So there are multiple reasons like cardiac reasons are there, non-cardiac reasons are there, physiological reasons are there for both bradycardia and tachycardia. We are not discussing the reasons here. However, we'll put a chart where you can see both bradycardia and tachycardia. Now we'll go to different types of tachycardias. That is more important than learning different types of rhythms in ECG. Most important thing will be tachycardias. So we'll see the tachycardia. Okay. So P wave is there, QRS complex is there, then P wave is there, QRS complex, QRS complex, QRS complex. So if the number of QRS complex are same sinus rhythm, you can see here for comparison. The number of QRS complex coming here, the numbers are huge. Then you can call it as tachycardia according to ECG. Whether you can call it a sinus rhythm or something else, that depends on the previous criteria. There should be a P wave, there should be a PR interval, there should be QRS complex. QRS complex come regularly, then we call it as sinus tachycardia. Sinus tachycardia can be due to fever, pregnancy, anemia, thyrotoxicosis. So many conditions can present with sinus tachycardia. But if the heart rate is more than 140, you call it as supraventricular tachycardia. Supraventricular tachycardia means tachycardia is originating above the ventricle, that means atrium, and it is producing heart rate more than 140. If it is 100, the heart rate is 100 to 140 you call it as sinus tachycardia, but to tell sinus tachycardia you should have again P wave, PR interval, QRS complex. Okay, so now we will be seeing different type of supraventricular tachycardia. So already we have told sinus tachycardia, that is not a abnormal rhythm, that is due to some conditions like anemia, thyrotoxicosis, beriberi, or like fever, anxiety, fear, blood loss. All these things can produce sinus tachycardia. Supraventricular tachycardia can be due to various conditions like heart disease, valvular heart disease, drugs, or some toxicities. So many conditions you can get supraventricular tachycardia. So we'll see now what are the different types of supraventricular tachycardia. Supraventricular tachyarrhythmia we can tell. Now you have SVT, proper SVT, and some other rhythms. Like that also you can classify. Okay, now we'll see what is supraventricular tachycardia. We already told that if the heart rhythm is originating above the ventricle, that is in the atrium, that is called as supraventricular tachycardia. It can be due to two important reasons. One is there is a re-entrant phenomenon occurring in the AV node, or a re-entrant phenomenon occurring in the AV area. Okay, so supraventricular rhythm can be again divided into AV nodal re-entral tachycardia or AV re-entral tachycardia. Whatever it is, it's a re-entrant phenomenon. The current is coming in this direction normally, but due to some abnormalities in the heart, it is re-entering. That current is re-entering either in the node or in the AV junction. So that produces tachycardia. Heart rate may be more than 140. So what you will see, you can see here, you may get or may not get P wave. That is very important. You may or may not get P wave. You may see P wave or you may not see P wave. But QRS complex are narrow. That means it is less than 3 squares and it is rapid. You can see it is rapid. It is rapid. So heart rate is very high, more than 140. But what is the advantage here is, not advantage, what is the peculiar feature is, RR interval is always equal. It is equal, RR interval is equal. That is the main diagnostic feature of supraventricular tachycardia. Or you can call it as tachycardia, supraventricular rhythm, where the heart rate is very high, it is regular. So it can be called as regular narrow complex tachycardia. So we can call here it as regular narrow complex tachycardia. So regular complex narrow complex tachycardia is otherwise called as supraventricular tachycardia. So supraventricular tachycardia, you have two important conditions. One is AV nodal re-entral tachycardia or AV re-entrant tachycardia. Whatever it is, the patient is having rapid heart rate which is regular and QRS complex is narrow. Now the aim in emergency room for this condition, the aim of the treatment in emergency room is to control the heart rate. If you don't control the heart rate, the ejection of blood that will be compromised. The amount of ejection of blood will be compromised. Patient may go to hypotension or shock. So our aim in emergency room will be controlling the rate. So this is supraventricular tachycardia, or you can call it as regular narrow complex tachycardia. Why we are telling it is regular? Because RR interval is equal. Why we are telling it is narrow complex? QRS complex is narrow. It is less than 3 small squares. So that is regular narrow complex tachycardia. Now we will see another important condition which comes as supraventricular tachyarrhythmia, that is atrial fibrillation. So here you know that SI node only firing electrical activity to ventricle. But in atrial fibrillation there are multiple focus which can fire electrical activity to the main conduction pathway, and that will be in an irregular manner. All this electrical activity will not be conducted to ventricle, it may be blocked here, partially it may be blocked. So what happens is, you get P wave in a like a base wavy baseline, then narrow QRS complex, irregular RR interval. So what is the difference between SVT to atrial fibrillation with tachycardia is, it is narrow complex but it is irregular. RR interval is totally irregular. So that is the main difference between SVT and atrial fibrillation. Whatever it is, what is our treatment? Is to control the rate. That's all. We have to control the rate. So this is regular narrow complex tachycardia. This is irregular narrow complex tachycardia. So this is atrial fibrillation. This is supraventricular tachycardia. So these are the two important supraventricular rhythms we should know in this condition. What is the main treatment? Main treatment is control the rate. If you don't control the rate, patient may go to hypotension and shock. Okay. Now we can discuss about ventricular rhythms. See, ventricular rhythms are, we already learned, atrial rhythms are always narrow complex. QRS complex is always narrow. But whereas ventricular rhythm means SI node is not functioning properly, AB node also may not be functioning properly, then the ventricle activity will occur, or ventricular activity superimposes atrial activity. That means ventricular activity comes before atrial activity and there will be continuous ventricular activity alone. So the current is produced in the ventricle and it go to the main system, then come to the conduction system. So it takes some time. So what happens is, you don't get P wave because SI node is not getting activated. No P wave. Since it takes some time, ventricular activity will become wide QRS complex. So wide QRS complex and tachycardia, this can be VT, ventricular tachycardia. Then if you don't treat that patient that time, sometimes it will go to irregular rhythm like this. This is called as VF. Okay, so in VT, again, if the patient is having symptoms of instability like hypotension, shock, chest pain or altered behavior, we have to take this patient for electrical shock. Or if the patient is fully stable, then we have differential diagnosis for this. We cannot explain all these things here, but this is called as wide complex tachycardia. So this is called as narrow complex tachycardia. This is called as wide complex tachycardia. This is wide complex regular tachycardia. This is irregular tachycardia. So like that you can differentiate all types of tachycardias like this. This is narrow complex regular tachycardia. This is narrow complex irregular tachycardia. This can be called as supraventricular tachycardia. Major causes are re-entrant tachycardias like this. Irregular tachycardia can be due to atrial fibrillation. Then if you are getting a wide complex rhythm, then it can be VT, and if it is irregular, then it can be VF also. Again, wide complex tachycardia, you have other differential diagnosis like SVT plus RBVB or LBVB or WP, W syndrome. So these are the differential diagnoses, but we will not be going into the details of all this type of rhythm. We are only talking about major rhythms in ECG according to ACLS protocol. So we have only 4 major tachycardias here. One is regular narrow complex tachycardia, that is SVT. Irregular narrow complex tachycardia, that is atrial fibrillation. Regular wide complex tachycardia, that is VT, or differential diagnosis can be SVT with RBVB or LBVB or SVT with WPW syndrome. Irregular tachycardia can be VF. So that is about tachycardias. Now we will talk about bradycardias. Now we will be talking about bradycardias. These are also rhythms come in ACLS protocol. So we already learned normal sinus rhythm here. So this will be something like a normal sinus rhythm. If the rate is going down less than 50, what is the problem? If the patient is having very low rate and it is compromising the circulation of the patient, then patient can have giddiness, dizziness, altered behavior, loss of consciousness, syncopal attack. All these things can be produced by this problem. Okay, so if the heart rate is something like this, something like this. Suppose this is 70 beats per minute, it may be only 35 or 40 beats per minute. We can calculate the rhythm rate that we already explained like this. We can calculate the rate. But if it is very low, what are the reasons for that? Again, you have to tell that whether the patient is having sinus bradycardia or something else. Sinus bradycardia means patient should have a P wave, they should have a proper PR interval, then there is a QRS complex. RR interval comes regularly, that is sinus bradycardia. So sinus bradycardia causes are different. There are multiple reasons for sinus bradycardia. You can think about 5X and 5Ts that will show a chart here. From that you can make out whether the patient is having something like that. Physiologically itself, patient can have sinus rhythm like somebody is sleeping, young children, or patients regular athletes. They also can have sinus bradycardia. Whatever it is, bradycardia have got different features, different causes that will show you a chart so that you can understand the causes for bradycardia. Now, another important cause for bradycardia is, this is sinus bradycardia, P wave is there, PR interval is there, QRS complex is there. QRS complex come regularly. This is sinus bradycardia, heart rate may be somewhere around 35. Like here you can see, here the rate is 300 by 3 is 100. Here you can put six squares are there. Suppose 6 squares are there. So 300 by 6 will be 50. So the heart rate is somewhere around 50. But this patient is having sinus bradycardia. Now we will see blocks, heart blocks. What is heart block? We will see. Then you will understand other causes for bradycardia. So you already know that SA node is there, then conduction to AB node, from there it go to the Purkinje fibers. So normally you get P wave, then PR interval, QRS complex, then T wave, next P wave. Okay. Now if there is a problem here, conduction there is a problem. What is the first problem? That is called as first degree heart block. PR interval is prolonged. Normally it is 3 to 5 squares, now it is more than 5 squares. PR interval is prolonged. This is called as first degree heart block. The earliest type of heart block, or the earliest changes which can occur in the conduction system which is producing a heart block, that is first degree heart block. This can be due to drugs like beta blockers, diltiazem or digoxin. All these things are there, but this is first degree heart block. Prolonged PR interval is first degree heart block. Now, if there is more problem in the conduction system, what happens is P is there, QRS complex is there, then again P comes, QRS complex comes, then again P comes, next QRS complex is missing. So, after every P wave, you should get a QRS complex. After every activity, you should get a ventricular activity, but that is missing here. That is second degree heart block. In second degree heart block itself, there are two types, Van-Gebach's phenomenon and type 2 second degree heart block. Type 1 is Van-Gebach's phenomenon, that is progressive PR interval and sudden drop of one QRS complex. Second type is there is no progression of PR interval, sudden drop of QRS complex. So that is second degree heart block. Third degree heart block is something like this. P wave comes regularly. So atrial activity is going on regularly. Ventricular activity is not related to atrial activity. So this is ventricular first. This is ventricular activity that is not related to atrial activity. So atrial activity goes regularly, but ventricular activity is totally irregular. This is irregular means their activity comes regularly, but it is irregularly coordinated with the atrial activity. So P waves come in its own rhythm, that atrium beats in its own rhythm, ventricle beats in its own rhythm, but it may be slightly low, but there is no association between atrium and ventricular activity. This is third degree heart block. So first degree heart block, second degree heart block, third degree heart block. So these are the common bradycardias we can see in patients. The last part of ACLS protocols will be, so we have learned about rhythm analysis here. Now the last part will be ST segment. Normally you have P wave, you have ST segment, PR interval, QRS complex, ST segment and T wave. If this ST segment elevated or ST segment depressed, both can indicate ischemic heart disease. A patient who is coming with acute chest pain, if V1, V2, V3, V4, that is anterior chest leads, or ST segment is elevated, then you have to diagnose it as acute myocardial infarction, anterior wall MI. If you do a troponin I or CKMB, it can be elevated. These patients should be taken for thrombolysis or primary angioplasty. If the patient is having chest pain and if there is ST depression in V1, V2, V3, V4, you have to suspect it as unstable angina. That depends on the leads, whether it is anterior leads, posterior leads, lateral leads. Wherever there is changes, we can call it as acute myocardial infarction or acute coronary syndromes. So ST elevation and ST depression also very important in ECG. Somebody come with severe chest pain, hypotension, if there is ST elevation in lead 2, lead 3 and AVF, it is inferior wall myocardial infarction. If somebody is having severe chest pain, if there is ST depression and TIVO inversion in V5, V6 and cardiac enzymes are normal, then it has to be diagnosed as unstable angina. So these are the common changes you can see in ECG according to ACLS protocol. We can learn more in practice sessions, you can do all these procedures in live sessions on mannequin, so that you will get a better idea about rhythm abnormalities, how to manage the rhythm, all these things. Thank you.